All right, thanks everybody for coming over and coming to my presentation. I'm Mark Newpower. I'm gonna talk about my proton planning experience with DirectArc, which is Mevion's arc solution in RayStation 2024A. All right, so to start, when we talk about arc therapy, we should start talking about IMPT, or the kind of the status quo of IMPT right now. And so when we talk about head and neck cancer with IMPT, we are limited in the number of beam angles that we can use, and the reason for that is because it just takes too long of a time. It would take us way too long to deliver 20 or 30 beams, and so typically for a head and neck patient, we would treat with something like 4 to 6 beams, maybe 8 or 9 if we had to get really crazy. But we know, because of our experience from the photon world, moving from static IMRT to dynamic IMRT with arcs, we know that that when you only use a limited number of beam angles, you are limiting the optimizer's ability to find the best dose plan. And so we know that the more angles that we can get, the better OAR sparing that we can get, the better tumor coverage that we can get, and that really shows up a lot in head and neck cancer, because we've got so many OARs in such close proximity to all of our targets. Starting at the top, we've got our eyes, our optic nerves, the brainstem, going all the way down, even down to your larynx. So there's a lot of really valuable real estate right next to these tumors that we have to pay attention to. And so when we are planning these IMPT plans, what we start out with is we just have to pre-select our beam angles. And so a lot of this just comes from experience, or maybe if you're lucky, you have a senior dosimetrist or physicist that passes down some best practices. But you really have to a priori set up your beam angles. But with arcs, what you do is you set up your arc coverage. Maybe you use full 360, maybe you use a limited, more of a partial arc, and then you select the number of beam angles per arc. And Eric actually did a great job of showing, if you guys were paying close attention, there was a button that said convert to PBS. So you can turn these into plans that we can deliver on our machine today. And so really what I want to kind of draw our attention to is the fact that, just like in photons, where we had a limited number of beam angles and we moved from step and shoot to arcs, we are kind of on the cusp of that for proton therapy, and that's where we're at today. So in our experience, what I did is I took 2 head and neck cancer patients from our patient database and then planned them in RayStation 2024A on our Mevion system. Again, that product is called DirectArc. It's important to point out, too, that this was a clinical version of RayStation, not a research version. So if you enter into a research agreement with RaySearch, you get all these fancy bells and whistles and all these cool platforms. But the results I'm going to show you today, everything was on a clinical version that you could buy, I suppose, today. And so after optimizing as arcs, we used just the single click button that converted from arcs to PBS so that we could deliver them on our PBS Mevion system. And then in order to see if these plans could be actually delivered on our system, what I did is I wrote a series of scripts that took out all the beam parameters and then took them out of that version of RayStation 2024A and then copied them back into RayStation 12A, which is what our clinical version is, and then shot them as a QA plan, and then performed some QA on it. So the first patient I'm gonna show is a bilateral head and neck patient, 7,000 centigrade in 35 fractions. It's an SIB plan, so there's also a volume going to 5940. And the main OARs to pay attention to here are the parotids, the brainstem, spinal cord, larynx, and tongue. The IMPT plan that this patient was actually treated with was a 5-beam plan, and the DirectArc plan that I came up with was a 16-beam plan. Both of these we were able to capture with a single isocenter. The figure here you can see is how the user, when they're selecting the number of, selecting their arc coverage and then selecting the number of beams, you can see I've got 8 on one side. Our Mevion system has a little bit over 180 degrees of arc coverage, so if you want to do full arcs, you add in a a couch kick, and then you do the other side. So this is what it looks like for the one beam that's going to have 8, one arc that's going to have 8 beams in it. And here's a 3-plane view of that patient. You can see we've got these big tumors here, but they're adjacent to, in the bottom right, you can see they're right adjacent. They're touching the parotids, and then you can see they're also close to the larynx. So for those of you that treat head and necks or see these on a day-to-day basis, these are really, really tough dosimetric plans to have to come up with. And so here's the DVH of that plan. You can see, starting off on the far right, we'll look at the CTV coverage. So the CTV coverage, there's not really a huge difference between the ARC plan and the IMPT plan. The coverage is good, but where you really start to make, kind of really start to make your progress is you can see that the OAR sparing, it starts to get good. The tongue, there's some volumetric sparing there, but more or less you can see that all the DVHs are shifted a little bit lower with the ARC plans. So that's kind of giving evidence to the fact that the more beams that we can have, of course, it should follow that the better we're able to spare some of these OARs. And then, in particular, when you're looking at the parodids, we're shooting for 2,600 mean dose to each parotid. We're barely able to scrape under that for the left one, and the right one, the IMPT plan wasn't able to meet that. But when you look at the DirectArc plan, what you can see is we're have a 500 to 700 centigrade dose sparing for the mean dose of the parotid. So, when I started showing these plans to our head and neck physician, she was stoked. She said, "Oh, we got to do this. We have to implement this, and this is something that's a big deal." And then, as a physicist, when I was looking at this plan and thinking, okay, well, if this was something that I would review in my clinic, we already saw from the DVH that the OARs are spared better, but from a more qualitative standpoint, what do these plans look like? So you can see the ARC plan on the left. The biggest thing that jumped out to me is these big smooth doses versus our IMPT plans. They're a little more splotchy, more heterogeneous in dose. They're going to have a higher hotspot in the CTV. But again, something that we saw in the photon world, we see these lower hotspots, more uniform dose because of the ability to utilize arcs. So we're seeing that also in our plan. In protons, we are always concerned about robustness. Are these plans, something that we could actually deliver and feel good about? Our robustness evaluation, we use 16 different scenarios, a 3 millimeter shift with a 3.5% density shift. In the worst case scenario, the CTV needs to have at least 95% of the prescription dose, has to cover at least 95% of the CTV, each of the CTV volumes. And so what you can see here is that these plans are robust. This plan did pass our robustness standards. And so at least from that standpoint, we think, okay, these are plans that we could feasibly deliver from that aspect. Then another really interesting kind of area that we as a community need to figure out is what's the number of optimal beam angles. You can see here I started with a 16 beam plan and I made it a 20 beam plan and then reran the same optimization, and you can see with the solid line is the 16 beam plan and the dashed line is the 20 beam plan. There's not really huge differences. There's a little bit of dose sparing that's a little bit better with the 20 beam plan, but if I were to go and take this to my physician, I would say, I don't think that there's really a huge difference between here, but perhaps where we're really going to get our gains is how deliverable the 16 beam versus the 20 beam plan is. So if we can deliver this more or less the same plan, but we can deliver it much faster, I think that would be something I would stand behind, and I would imagine the physicians would be interested in that as well. And then I talked about how I QA'd this plan on our system, and so when we did all 16 beams and we did our analysis, this plan passed QA. So although we can't deliver the ARC plans because we haven't retrofitted our system yet, we could deliver them. And so these plans that we actually made, in the computer, we could actually bring them to fruition, in real life. So we were really, really excited about that. The second patient I'm going to show is another bilateral head and neck cancer patient, 6,000 centigrade and 30 fractions, another SIB, so we've got volumes to 6,000 and 5,600. And the OARs that we're going to pay attention to here are the parotids, the brainstem, the eyes, and the mandible. The IMPT plan that we came up with was a 9-field plan. So these are really tough, really long delivery times, really tough on the patient. And because of the length of the targets, we had to deliver it as a double ISO. And so we did the same thing as the double ISO center plan. A DirectArc plan we came up with was 24 beams. And you can see here, this is an even more challenging case. We have a CTV 6,000 volume right between the eyes. And then, of course, the bilateral portion of the targets, again, right abutting the parotids. So really, really tough, difficult, even for protons. These are really, really tough patients to plan and come up with a good plan for. Here is a graphic showing the angular distribution of the arcs for the upper and lower isocenter. Because the lower isocenter was mostly encompassing those bilateral nodes, then we gave up some of the coverage on the anterior portion just to see if we could make a good plan with a few number of beam angles. And then the upper isocenter, that was more focusing on the volume right between the eyes. So we had to put angular coverage there. So on the left isocenter, we had 5 beams per side, so 10 total beams. On the right side, there was 7 beams per side, 14, and that's where we get our 24. Our 10 and 14 is our 24 total beams. And so looking at the DVH, this is where we can really start to see some of the huge advantages that we can get with using arc plans. So just looking at the CTVs on the far right, we have the same coverage for the arc plan versus the IMPT plan, but we see that much more uniform dose and even lower dose, lower hotspots there. And then when you look at the eyes, you can see a massive shift in the DVH moving over to the left. So we get huge sparing for the eyes, and those are right. There was a 6,000 centigrade volume right in between the two eyes. We have better volumetric sparing on the mandible, and then we have amazing sparing on the parotids, something super exciting, and the same on the brainstem. So when I showed this DVH to our head and neck physician, she was adamant, like, this is incredible. We'd love to deliver this. We'd love to have this for our patients now. And then doing a little bit more analysis on the parotid dose sparing, some more numbers. We're barely just skating under that 2,600 mean dose to each of the parotids with the IMPT plan, but with the DirectArc plan, we're able to cut those doses in half essentially, and reduce the mean dose to those parotids significantly. And then when you use the Dutch model and you estimate the grade 2 xerostomia after 6 months, you can see that it's about a 16% decrease in xerostomia risk. So something on an outcomes, focusing on outcomes that I think this would make this technology very, very exciting. And then now kind of stepping back and looking more kind of bigger picture, Eric did a good job of introducing some of this already, so I'll kind of go a little bit faster. But we saw that from Dr. Frank's work from his clinical trials that are showing that IMPT is just at the cusp of starting to show that IMPT is better than IMRT for head and neck cancer. And in this very limited study, but also in some of the papers from Trento that are coming out, that proton arc therapy is showing even better dose distributions than IMPT is. So I think that's a natural question that begs as well, could this even lead to better outcomes in patients treated with this technology? There's also some interest in doing proton shoot through. Like Eric mentioned, using that really, really sharp penumbra where you really need it the most. Give up a little bit of dose peripherally, but really sharpen up those dose distributions right next to your OARs. And then, of course, you can also get range verification information from that as well. And then I briefly touched on it, but the question of how many beams is enough is the group in Trento, when they looked at this, they looked at the difference between 20 and 30 beams, and they basically showed that you're not really gaining more by going from 20 to 30, but of course that would be a huge difference in your delivery time. So but that's an interesting thing that we really need to flesh out, is how much is good enough, and where is that balance between these great plans that look good in a DVH and then something that we can actually deliver on a machine. And then, of course, LET optimization is fascinating. When you have more beam angles, you've got a larger number of area to kind of sculpt that LET distribution and really be able to move that around. And then kind of getting to the end here, this is my colleague, Christina Henson, the head and neck physician I was kind of alluding to, and she wanted to give her take on this information. And so she wanted to draw your attention that when we moved from step and shoot to VMAT, we saw much better conformality, especially doses to the parotids and the oral cavity was significantly reduced. But right now for IMPT, we're not quite there yet because, again, we're constrained on that delivery time. But perhaps proton arc therapy can really harness the benefits, if we choose to use it, the Bragg peak, and have no exit dose, but with that conformality of arc therapy. We anticipate big benefits in plan quality, reduced dose to our OARs. She even said, maybe this becomes even a new standard of care. there's of course a natural application to other disease sites. The brain would be one of them. Doses to the or dose and LET right near the brainstem, I think could benefit a lot from ARCs. And then of course higher patient throughput. If we can treat these people faster and treat them better, of course we're going to be interested in doing that and give our patients a better experience. And so in conclusion, just as the field started out with static beam IMRT from fixed angles and then moved to arcs, we're really kind of on the cusp of that in proton therapy. And so it's a really exciting time, and hopefully in the next year and the next coming years, we can talk about how arc planning gets implemented in clinics. So I want to acknowledge some of my collaborators, my graduate students, and some of the physicists in my institution, folks from RaySearch that helped me get this set up, and then as well as folks from Mevion who have helped support this and push this along. So thank you.
All right, thank you, Mark, so much. All right, so if we have any questions for Mark, we are. I'm sure you would be able to answer them. Otherwise, I saw that you put your email there, so I would encourage people to reach out to you if they would like to learn more about Proton Arc and the experience that you already have. And then talking about the future, what would you see what's needed to scale Proton Arc Therapy in the clinics?
So our vendors have to work on it. So I work at a Mevion center, so Mevion is actively working on their solution, DirectArc. But it's going to take some time for the vendors to integrate, in this case with RayStation, to figure out how that's actually applied. But I think some of the results like this show how exciting and show what the possibilities could be.
Definitely. All right. So thank you so much.